Yes, just go ahead. Just go ahead. Yeah. All right, yeah. Just say graduated from the University of Nigeria in Nigeria, and then got an MPH from ETSU, and now third year resident at ETSU. Yeah. Thank you. I'm so nervous. Okay.
Good morning and welcome to Psychiatry Grand Rounds. If you are an attending, resident, or medical student who wanted to claim attendance or CME credit, please see the information posted in the lobby. The Grand Rounds Committee asks that you please silence your cell phones and refrain from unnecessary use during the presentation. This morning I have the pleasure of introducing my colleague, Dr. Joseph Ikekwere. Dr. Ikekwere completed his Bachelor of Medicine and Bachelor of Surgery at University of Ibadan College of Medicine in Nigeria. He completed his Master's of Public Health and Biostatistics and Epidemiology at East Tennessee State University. And he is currently a third-year psychiatry resident at the Department of Psychiatry at East Tennessee State University. Please welcome Dr. Ikekwere.
Good morning, you all. My name is Dr. Joseph Ikekwere, and the topic of my presentation today is a depressive disorder in the setting of HIV. Distant uncle that had early symptoms of HIV, but it took him more than 5 years to agree to testing and diagnosis of HIV. After the whole family chose to explore all cultural and religious factors that might be responsible for his depression. And so it took us about 5 years to eventually figure that out. And working with Dr. Goodkin, I've really been able to learn a lot about HIV AIDS and its effects. The lifetime prevalence of depressive disorder in HIV positive individual range as high as 33%. And there have also been studies that have shown that it could be even as high as 40%, and which is about times 2 or 3 of the lifetime estimate for major depressive disorder. Here is a proportion of all people with HIV between the ages of 15 to 49, shown by territory size. And here, if you looking at the United States, it's pretty small compared to the sub-Saharan Africa. And you see sub-Saharan Africa accounting for about 2/3 has the highest burden. And there are a lot of cases every year. And if you also look here, if you pay a particular attention here, in Southeast Asia, there's a lot of new rates of HIV/AIDS diagnosis, especially in India. And then if you look on top of the map also, there's been, due to the new kind of reusing of cap needles in Russia, is getting more prominent also on the map. And here is just a little bit of background about the HIV virus itself. It's a lentivirus, and it has the GP glycoprotein 160 here, which is it uses to attach, which is an envelope protein, and you have the glycoprotein 120 here, which is one of the docking protein, and as well as the transmembrane protein GP 140 that enables the virus itself to attach, and then it goes to the it attaches to the CD4 T cells in humans, and then with the help of other co-receptors like the CRCX4 and CCR5, then is able to go in and then releases the viral DNA with the inclusion of all these other proteins that are present, the reverse transcriptase, protease, and integrase, which is what the antiretroviral medication typically target. Here is a diagram showing HIV progression from once someone gets infected, there's an acute phase where the virus, HIV virus, is multiplicating pretty fast. And then at that point in time, the CD4, even though it's still normal, starts kind of shutting down. And then the body fights back by releasing the immune response, mounting immune response, which drives down the plasma, the HIV virus itself. And then it stays in the body for a while, for a long time, until once individual starts developing symptoms, non-specific symptoms like thrombocytopenia and other symptoms that manifest physically, and then eventually the individual might go ahead to develop some AIDS, which is defined as acquired immune deficiency syndrome, and is defined as whenever the CD4 cells goes below 200, or there's presence of opportunistic infections like pneumocystis jirovecii pneumonia, and some cytomegalovirus in the retina, and Mycobacterium tuberculosis. Here is an iceberg that depicts where the infection typically starts the first time, asymptomatic, and then you start having some symptoms here, and then a lot more complex symptoms. And after so many years, then you start having some of those 8 opportunistic diseases that I already mentioned. And I just also wanted to correct an impression because that says the highest mode of transmission of HIV is not homosexual, it's actually heterosexual worldwide. And here in the United States, with new HIV diagnosis, occurs more in minority male homosexual. So you find the African American population accounting for the largest. This is statistics from 2016. and you followed by the Hispanic homosexuals, and then you see the African American female heterosexual right there. By race, African American as well as Hispanic are disproportionately affected by HIV. And if you look at the proportion here, 48%, so even though African Americans make up 12% of the population, they account for about 44%, and then Hispanic are about 18% of the US population, they account for about 25%. So in total, they account for more than 2/3 of HIV diagnosis. And then another significant thing, going by geographical location of geography of the United States, the South account for the highest rate of HIV, including Georgia, Tennessee, and some other states in the South, while the Midwest has the lowest rates. Here is here's the diagram showing this same age group. So in major depressive disorder, it's about the same age group. Groups at heightened risk have a higher risk for depression, which leads to even more increased risky behaviors. Depression can also be a consequence of either the HIV-induced brain injury or antiretroviral medication. In one of the articles published by Dr. Goodkin, actually stated there that one of the ways to differentiate would be anhedonia. There's a significant low motivation or drive in HIV-induced brain injury versus if it's coming from antiretroviral medication. Here is a clinical spectrum of hand. Here there's still kind of neuroprotection. So the prevalence rate of HIV-associated, so the hand stands for HIV-associated neurocognitive disorder, which has these three components and these three spectrums. So, but the prevalence is about 50%. It's quite high. So out of which asymptomatic neurocognitive impairment, where you have some cognitive dysfunction, especially having to do with memory, both working memory as well as information processing speed, a little diminished. But here there is no activities of daily living are pretty intact. In mild neurocognitive disorder, there's still cognitive dysfunction, and then there's a mild neurocognitive dysfunction, but activities of daily living is a little affected. And then here in HIV-associated dementia, there is a lot more significant, the activities of daily living is more significantly affected here. And this has about 2% prevalence. Here are the prevalence I already mentioned here. For asymptomatic neurocognitive impairment from the 50%, you see 33% prevalence for asymptomatic neurocognitive impairment and 12% for mild neurocognitive disorder. And so mostly, in summary, major depressive disorder occurs at least greater than 3 times the rate of general population of people living with HIV/AIDS, and there is a frequent comorbidity in HIV infection that has been associated with worse treatment outcomes and increased mortality. And major depressive disorder is associated with delaying initiation of antiretroviral because a lot of times when they get depressed, they are not likely to want to take their antiretrovirals, and then they adhere poorly, and then accelerates the disease progression, which also predisposes them to illicit substance use. Now, on the role of inflammation, there's been different theories propounded, but one of them has to do with the balance between pro-inflammatory cytokines and anti-inflammatory cytokines, which typically will alter which is altered and then causing some mood symptoms due to inflammation, and you see that in comorbid depression associated with other inflammatory conditions, including HIV/AIDS. And here is a diagram to depict that. I'm going to just talk about this a little. Here you see the body, so when so this is the blood cells, you find the body trying to protect itself by releasing the monocytes are mobilized from the white cells, and then a lot of them will extravasate and come out into the cell. Right here, there's a lot of monocytes here, and because there are a lot of them here, there's this perivascular coughing around this region, and they get activated into tissue macrophages, and then mounting the immune response, they start releasing some chemicals and all of that as multinucleated HIV giant cell. So you have a lot of monoamines released here, some other chemicals, and then that typically will cause a lot more destruction on the brain. If I go back here, there's, they also go through the blood-brain barrier, and then because of increased permeability, and then they also go into the other mechanism I just explained here, and then they go ahead to release all these neurotoxic factors, the free radicals, and then which eventually will cause a direct neurotoxic effect on the neurons of the brain, leading to neuronal apoptosis. And I'm also going to be getting into this part in the other part of my presentation. Recent studies have suggest that increased immune activation is associated with higher risk of depression in HIV infected individuals. HIV infection stimulates rising levels of like I already mentioned, pro-inflammatory cytokines from activated macrophages, especially interleukin-6, 1-beta, tumor necrosis factor, and that eventually turns out to give some of the sickness behavior that we see in patients, like with sleep disturbances, anorexia, loss of appetite, and sleep problems. There's a study here published in 2018 by Franklin TC that shows pretty much using animal models. And here you find, the model is based on chronic unpredictable stress. So looking at the microglia molecules in these mice, they saw that inflammasomes like the pathogen-associated molecular proteins and danger-associated molecular proteins here, so one of them is high mobility box index found on the surface of the microglia surface, typically in the hippocampal area. And so what happens, there's an upregulation in one of those inflammasomes, like the high mobility protein box 1 and RAGE messenger RNA. They cause a lot of morphological changes in the hippocampal microglia, and this increases vulnerability to anhedonia that is found in depression. And in this study, they actually infused high mobility box protein 1 into the hippocampus, and they noticed significant anhedonic behavior in these mice. So I already talked about this, covering the inflammation part, and some other theories that have been postulated has to do with dysregulation of the HPA axis. HPA stands for hypothalamic pituitary adrenal axis, and also there's altered synthesis in catecholamines, pretty much the catabolism of catecholamines. And then there's also another theory that has to do with mitochondrial bioenergetic dysfunction, and the stress responses has to do with cortisol is really involved here, and it's a lot of this is actually about cortisol pathway. And here is the HPA axis here, and there's been a lot of, I know Dr. Goodkin once gave a presentation on diet as well as depression, and here it is postulated that a lot of the Western diets have poor quality. They have a lot of advanced glycylation end products, which typically are risk factors for depression. And what happens is, after you, once you eat, all these things go down to the gut. They are acted upon by microbia found in the gut, and the increased permeability, and they're releasing some little bit of inflammatory cytokines that typically will evade the blood-brain barrier by going through the psychoventricular organs that is not covered by blood-brain barrier, and then they have a direct effect. Then those cytokines go straight away and have a direct effect on the hypothalamus, causing it to release the CRH, corticotropin releasing hormone, going to the pituitary, releasing adrenocorticotropic hormone that goes to the adrenal cortex, releasing cortisol, and a lot of cortisol are released, as well as some other biogenic amines. And you find that the cortisol here is upregulated. So if you go through the physiology of a positive feedback mechanism, a lot of cortisol are being produced. Now there's a problem with the negative feedback loop, which leads to more cortisol being produced. And when that is going on, there's a desensitization that happens at the cellular level that leads even to more interleukins being produced, like pro-inflammatory cytokines being produced, and which eventually will still lead to depression. So this is one other theory that has been postulated. This is pretty much the summary of what I just said. All right, and recent studies also suggest that altered synthesis in biogenic amines, so the tryptophan serotonin pathway, as well as the phenylalanine to dopamine pathway is affected. And here I'm going to be pointing to some, I'm not sure if I have the enzyme, but there's a decreased enzymatic conversion for the phenylalanine to dopamine pathway, as well as in the tryptophan to serotonin pathway. Here is a picture that shows L-tryptophan here being converted. There's a hydroxylase enzyme, tryptophan hydroxylase enzyme, that typically converts to 5-hydroxytryptamine. So, and then there's that typically will go also to forming serotonin. So now, if there is a blockage in any of this pathway, blocking the 5-hydroxytryptamine pathway, or there's a reduction, it's not moving forward such that you have a lot of serotonin, the tryptophan pathway could shunt to another pathway of tryptophan that typically will lead us to it's called the kynurenine pathway, or the let's see here. The kynurenine pathway, or quinolinic acid. Quinolinic acid pathway are part of the kynurenine pathway. So either you have the decrease in activity of enzymes around this part that prevents the pathway from going this way, or you have low tryptophan, or there's increased activity of the enzyme. It's called the IDO enzyme, the indolamine 2,3-dioxygenase pathway has increased activity, so it's shunting the whole pathway from tryptophan, making a lot more of kynurenine, or the other one that I mentioned. It's a little challenging to pronounce that. Linoleic acid. All right, so then the other pathway that I wanted to mention is the pathway of phenylalanine. So it's an amino acid here, and then phenylalanine is here. There's a tyrosine hydroxylase enzyme that typically goes to tyrosine, and then it goes all the way to L-dopa, and then eventually to dopamine. Now, if there's a problem affecting the tyrosine pathway, which is the rate-limiting enzyme, there's going to be a lot more accumulation of phenylalanine. Dopamine is not being produced, and then that's another theory postulated for depression. So I already mentioned that the tryptophan goes through the kynurenine pathway, favors it, which also leads to eventual production of NAD, nicotinamide adenine dinucleotide, which is a coenzyme for ATP metabolism. There's also been links to dysregulation of the T helper 1 cells and Treg balance, contributing to inflammation. And then, like the antiretrovirals have been shown to reduce tryptophan catabolism, which doesn't block, which enhances the tryptophan to serotonin conversion. Here's the pathway that I just described, having the quinolinic acid, which are neurotoxin and conversant, and typically would distort the NMDA receptors, leading to neurotoxicity and then apoptosis. The other theory has to do with mitochondria. The mitochondria has this SI, there's SI kinetins typically in the body. Yeah, so there's acylcarnitines in the body that typically helps the fatty acids to go in straight away into the mitochondria. So if it's defective, there could be problems. It's going to lead to a non-production of ATP that is going to lead to the membrane. It's not going to be, the membrane, there's going to be loss in stability of the membrane. There's going to be modulated the neurotransmission. It's not going to be balanced. It eventually leads to a lot more excitotoxicity and then apoptosis that gives us depression. And here are some, just pretty much what I just said. Alterations in acylcarnitine levels are used to diagnose genetic defects in mitochondria, beta oxidation. And several studies have found evidence of altered mitochondrial function or decreased ATP production, so typically in the muscles of people that have lifetime diagnosis of MDD. And the lifetime diagnosis of MDD in these individuals has a prevalence rate of up to 50%. So there was a study here that reported about, like I said, reported lifetime diagnosis of major depressive disorder and greater than 50% of patients that have this type of mitochondrial disorder. And then likewise, some branch chain amino acid, like branch chain amino acid typically with the two catabolites called the 3-methyl-2-oxovalerate and 4-methyl-2-oxopentanoate has also been typically in the liver. Also could tell us about a dysfunction, could predict depression. If anyone has problem with this catabolite, pretty much the branch chain amino acid, it could also tell us how depressed the individual could be. BCAA are catabolized in mitochondria and serve as an alternative energy source for metabolically active tissues. Here are peripheral biomarkers for both depression and HAND, including highly sensitive C-reactive protein, D-dimer, neurofilament, soluble CD14, which is a marker for monocytes, and then interleukin-6, tumor necrosis factor, are all like peripheral biomarkers you can actually monitor. And for biochemical markers, just like I described earlier in my slide, we have increased the IDO, so increased activity of the IDO, which is the rate-limiting enzyme that shunts to the kynurenine pathway. So it's also been measured, and and also the activity has been studied to try to predict poor CD2 cell for recovery. If you have decreased tryptophan or increased kynurenine to tryptophan ratio, could also be another predictor. And there's another study here that shows that typically predict the severity of depression by measuring plasma acylcarnitine levels. So you have these 6 metabolites. If there's any problem, it can tell you how severe a patient could be. And then this other branching amino acid could also assess liver mitochondrial function and influence glutamate synthesis. And a study published in Neuropsychobiology by Kumar, including Goodkin in 2001, found no significant correlation in the CSF 5-hydroxytryptamine or serotonin in association with early HIV with low CD4 levels. For treatment, there's been different treatments that have been postulated, and some of them include the use of SSRIs, including Lexapro. And here in this study, for monitoring of patient response, they found out that monitoring the CRP, the C-reactive protein, if it's less than 1, a patient shows response to Lexapro, and then if it's greater than 2, they have better response to a tricyclic antidepressant like amitriptyline. Other anti-inflammatory agents have also been used, like antibiotics, including minocycline, and then some COX-2 blocker like celecoxib. Then for the use of antidepressants reduces both affective and neurovegetative symptoms of HIV. And the reason why Celexa and Effexor are coming up here on top of the list is because they tend to have the least drug-to-drug interaction. And then I also want to point our attention to the low dose bupropion here, because bupropion by itself has a higher risk for seizure. And so now if you combine the seizure in depression with a seizure that is as high as 50% in people that have HIV/AIDS by those neurotoxins that I already highlighted, it could even make it worse for patients. They could come down with seizure. And another thing I wanted to mention here is Prozac is typically not favored because of the long half-life of the metabolites called norfloxacin, because of the interaction of the cytochrome P450 with antiretrovirals. Treatment of hand. Combination of antiretroviral therapy has been shown to be the only option in preventing or delaying the progression of hand, with a special focus on the highly CNS penetrating antiretrovirals. Psychostimulants have also been shown to be pretty helpful to treat, especially for concentration and attention that could be poor in hand patients. And the use of cognitive neuro rehab techniques has also been shown to be pretty helpful in early stages of hand. So sometimes they do the attention focus kind of program, memory kind of program, or spaced out memory. Pretty much like for something that they know about. Like for instance, you could tell them to tell you when their appointment is, what day the next day they are going to come back, or how to take their medication, things like that, to help improve their memory. And this slide essentially is showing the subcortical parts of the brain, and especially in HIV positive individuals that are currently on antiretroviral, that are stable on antiretrovirals. It shows that typically, especially the caudate, the amygdala, and the part of the corpus callosum, they all show reduced subcortical volumes. There's no evidence-based treatment so far, but patients could benefit from combination of antiretroviral and antidepressant treatment. These are for individuals that have comorbid depression with END. The future is to develop single medication treatment that could improve both the major depressive disorder and END. There's been studies looking at the use of PET with radioligand. Here is PK 1195 that typically will bind a translocator protein and then shows an increased uptake in terms of depression. So this is for depression. You find increased uptake in anterior cingulate cortex and the insula, and this has been associated with this has been shown to be increased in patients that have major depressive disorder with suicidal thoughts. And then for HIV/AIDS, there's a more soluble, there's a second generation, more penetrating PET radioligand that have been used. It's called the PBR28, that have also shown increased uptake of the microglia especially in the parietal, occipital, and the global pallidus area of the brain, and it's been shown to be significantly increased in HENS patients with cognitively healthy asymptomatic neurocognitive impairment. Therefore, we suspect that comorbid major depressive disorder and HEND are even more likely to show increased neuroinflammation by TSPO, because the depression is showing it, the HEND is showing it, then we suspect that it might even be more for those that have both. In conclusion, the comorbidity of HIV/AIDS with major depressive disorder is of clinical importance to address, because they are both particularly common clinically. And even though limited data exist for optimal treatment of both of the comorbid condition, but so far integrated approaches with the use of antiretroviral and targeting any of those pathways that I mentioned, including the monoamine metabolism, mitochondrial dysfunction, may be very beneficial for now for preventing and treatment of depressive symptoms of patients that have both. But the future is currently being directed towards dopamine agonists and anti-neuroinflammatory agents as depicted by the transmembrane protein. Special thanks to Dr. Goodkin and then also Dr. Kendall too. And Dr. Goodkin, especially for encouraging me in developing the topic and the content. He also has a lot of, is part of the international collaborative body working on different projects currently in my country, Nigeria. And also is an authority, as an authority in mental health research and treatment with people living with HIV. He authored and was quoted in most of my references cited. Here are my references. Any questions?
Thank you for that very, very detailed presentation. So one of the things I wanted to ask you about was you talked about, and I think it was related to depression, well, within the HIV population, I believe. You talked about that Celexa has been used, citalopram, venlafaxine has been used. Elsewhere, you talked about looking at blood levels where, depending on whether it was less than 1 or greater than 2, it reflected whether citalopram or nortriptyline might be effective. So I guess I was wondering why nortriptyline was not mentioned within this group, per se, if that's what's been looked at as predictive for a particular subpopulation, I guess, of HIV-depressed patients?
That one actually is mostly for just depression. The role of inflammation and depression only. That was what that study was about. The other one? This one.
So would that not make sense that that would have been studied then within the HIV population as far as a treatment medication, nortriptyline?
To date, not a lot of different antidepressants have been used, but here in this particular study, which was by Huha in 2014, it was pretty much looking at those two agents. So was published in the American Journal of Psychiatry. The title was an inflammatory biomarker as a differentiation predictor of outcome of depression for both Lexapro and nortriptyline. So this doesn't really have to do with the HIV patient.
Right. But given what you've talked about, inflammation within the HIV context,
Yes.
it might make sense that that could have been potentially used as an agent. I do understand why it may be problematic in a vulnerable brain as far as side effects, in particular with nortriptyline. One of the other advantages of nortriptyline, however, is the compliance can be a big factor with any psychiatric patients, but it may be even more so with HIV, so that because of blood levels with the nortriptyline use, that will be certainly something to be able to measure whether compliance is happening or not. The other thing I believe you mentioned, and I want to make sure, because I know you've talked separately about depression per se and HIV, but you also talked about use of a dopamine agonist as far as potential treatment. And I think elsewhere you mentioned stimulants, so that they could be used with, I wasn't sure if that was with hand per se or with depression, but it would certainly help with both, I would think. Yeah, so here you mentioned hand, but psychostimulants can also be used with severe depression as well, so it might do a dual benefit from a clinical standpoint.
I'm sure maybe Dr. Aguki can help me out here, but what I guess for the symptomatic treatment here is mostly for the attention concentration that could be part of the hand for some of these patients. So I believe that's probably why the psychostimulants could play a role for depression. Okay.
Yeah, they wouldn't be. I would just say that the psychostimulants wouldn't be favored as a focus for comorbid major depression with hand, because you're talking about the need for long-term treatment, and generally the psychostimulants, even in cognitive impairment with hand, have been looked at as a secondary focus because we don't want to keep patients on psychostimulants long-term. And typically the the treatment for hand has to be long-term currently. We're hoping that we'll be able to develop treatments that are more pathophysiologically based than palliative, essentially, which is what the psychostimulant effect is vis-a-vis a hand, because it's replacing a dopaminergic deficit. That's part of the pathophysiology of hand.
I may end up handing this back to Dr. Goodkin, but I bet you have some ideas about this. With all the review you did of the mechanisms of action, very interesting review, it surprises me that cholinesterase inhibitors can't be beneficial here. So I presume that means that there's been a fair review of the cholinesterase inhibitors in this area, and they haven't worked out very well?
I'm not sure about that. I'll defer.
No, actually, the acetylcholinesterase inhibitors haven't really been a major focus in the treatment of hand, also because of the pathophysiology of hand. So many times I am giving a talk about hand and I get asked the question, well, Dr. Goodkin, we know the cholinesterase inhibitors work for cognitive impairment. Why aren't we using that in hand? Well, it's because in hand, acetylcholine hasn't been shown to be specifically depleted as opposed to dopamine. And that's why there's much more of a focus of dopamine in hand than acetylcholine.
So in as much as some publicity going to have to defer to Dr. Goodkin in there. Okay, yeah, this last part. I know there have been different, I saw different literatures that show a CSF of 5-HT has been shown to be pretty low for those that are depressed only. So, and then also there's some other literatures that will say otherwise. But here, for the particular study that was done in 2001, published in Neuropsychobiology, including Dr. Goodkin, they, from the particular research they did not find any association between measuring that and prediction of and patients that have with early HIV, patient with low CD4 count in early HIV. I don't know if you have more.
So, in other words, in terms of the relevance of the SSRIs, specifically in looking at depression and HIV, as well as hand, we are interested in the effect of the SSRIs, particularly as anti-inflammatory and neurotrophic agents. And in fact, a recent publication showed on paroxetine that there was a positive effect on hand in the use of treatment of these patients with paroxetine. So there may be other effects of the SSRIs not related to actual CSF levels. And also, the other thing to remember, of course, is that CSF doesn't reflect brain tissue levels necessarily.
Any other questions? Thank you, Dr. Ikekwere.